Recording. Okay. Yeah, you guys kind of know some of this stuff already, so not too bad. And then next week, guys, upper extremity arteries, or is it vein? Of course, I can't remember if it's an artery or no. Have you already done? Did you already do veins with the Dr. G? I mean, upper arm veins, not so much. Okay. Shoot. All right. I need to figure that out before I let you go. It's either upper arm arteries or veins. Kind of doesn't matter. It's well, it matters for your reading, of course, but same difference. DVT studies, mapping studies, arterial studies, and a lot of it is just repeated. It's just different anatomy. So, and arms are fun. In fact, when we go back next week, we'll be. I don't know. I don't know about Tuesday, but certainly by the following week, girls, we're going to have you wear like you have spaghetti top dresses where you have as much of your arm and shoulder that we can see. Tube tops, I don't know. Don't know about tube tops. Anyway, all right, chapter 12. Going through. Low extremity arteries. Reason why we're doing these, we've already talked about this in the previous chapter, but claudication leads to limp. Ischemia, in other words, tissue damage or tissue pain due to a lack of O2. Anyway, rest pain. If you have rest pain, you have peripheral arterial disease, and even when you're resting, you're laying down 2 hours and you're still in pain, that's really bad. That means that even when your body should be relaxed, those arteries are still wide open. They're still trying to get oxygen, and so it's not just during exercise. After that, you start to get ulcers. Ulcers occur because there's not enough blood going there, and literally tissues is starting to die. And then gangrene. We saw. Oh no, you will see, if you haven't already, seen some pretty nice gangrene on the toes on that asynchronous assignment that I created. Pallor. Whiteness or paleness to the tissue because of a lack of blood, low or no pulse. So doctor, I wouldn't be the one to know anyway. I don't understand pulses, how people do it so well. Maybe I have insensitive fingers, I don't know, but I never feel a pulse anyway. But if doctor can't feel a dorsalis pedis pulse or a posterior tib around the ankle, that's an indication. Paralysis, if you're not really even able to use a limb, it could be because of just total lack of blood supply and oxygen. Paresthesia, which is kind of like painfully numb, itching, tingling, and then general overall pain. Those are all indications of peripheral arterial disease. That's the number one thing we're looking at. When we're talking about arteries, that's the number one thing. And the other thing that we could be looking at is aneurysms, which is spelled wrong. That's all right. Blue toe. We've already mentioned, if you have a blue toe and it's like overnight, like really fast, like one day your toes, your foot, half your foot, your whole foot suddenly goes blue or black, that may be you've dropped an embolism. That embolism probably comes from an aneurysm. So the other thing is that if the doctor feels behind the knee and finds a pulsating mass. Could be a popliteal aneurysm. So some of the indications as to why we're doing this. Some of the risk factors. So diabetes mellitus, hyperlipidemia, hypertension, tobacco use. If you have a history of coronary artery disease, unfortunately, it's probably not just the heart. You're probably seeing it in other parts of the body. Chronic renal insufficiency, which really is also a common problem of diabetes mellitus. Obesity in general is not good for the arteries. Sedentary lifestyles, exercise. Guys, I think I've told you this before, but I used to do, now really talking about carotids, but I used to do just hundreds of carotids every month. It was, I liked them, but sometimes I hated them. And I used to be able to spot someone with bad carotids as they walked in the room and as I started talking to them. And then I would know if someone had fine carotids by talking to them. And I'm not talking about like small differences. I'm talking about like real disease. So I've had 90-year-old women come into my room and they're mentally there. They move as quickly as any 90-year-old will move. My mom was a good example. And I would invariably, I would know that their exam is going to be fine. And I would also, I would always talk to them and say, so how much do you exercise? And they would always say that, yes, they walk every day, they exercise. In my mom's case, she played tennis her whole life. Exercise doesn't have to be brutal. It's just simply moving is so good for you and good for your brain, because if you're getting clots, not clots, sorry, if you're getting a plaque all over in your legs, your carotid, around your heart, trust me, you're getting it in your brain too, and that slows you down. So yeah, I just be able to know right off the bat what kind of exam it's going to be. Unfortunately, though, heredity, I spelled it wrong, didn't I? Now I can't think of how to spell it. Heredity. Gender, I put a question mark here because the book was pushing gender a couple of chapters ago, and then it contradicted itself. So I don't know, in my opinion, male, female, I think we're about even when it comes to just general plaque. Anyway. And then age, of course. Age is the enemy that none of us can fully avoid. So generally, you're looking at older people when you do these exams. All right, so for the lower extremity arterial, not a bad idea to scan the aorta and iliacs. So if you have disease in the legs, there's a very good chance that you have disease in the iliacs and the disease in the aorta. Not always easy to see. Obesity makes it difficult. Intestines make this difficult. But it's not a bad idea to at least try. And of course, it depends on where you work and all that stuff and what the policies are. But a lot of times we find insufficiency and it's not in the legs, it's up higher. So generally each area, and this is the same thing as before. Let's say, let's just skip the aorta and iliacs. We'll start with the common femoral artery. Yeah, probably one location. Deep femoral artery, once. Femoral artery, 3 times, proximal, mid, distal. And this is minimums. This is not, you found disease, then you have more. Proximal, mid, distal, popliteal, minimal one, but I do at least 2 or 3 locations personally. The popliteal is a bit of a trouble area, so I like to get more than one image there. And then you have 3 vessels: ATA, PTA, and perineal arteries. And then the distal sections of those, so the dorsalis pedis. But in the tibial arteries, proximate distal is probably required from most locations or for most labs. So we can go over that again, but generally each location is scanned grayscale, color, and spectral. Some places might skip the grayscale. Generally not, but grayscale is definitely helpful. I mean, you see plaque, it's helpful, but some places they just go with the color and the spectral, and if everything's fine, they keep moving along. Oh, that was the other thing. These are really long exams. So you got to concentrate on not making them longer than they need to be. So if you start off with triphasic flow and you're inching along every centimeter, you're taking another scan and you're looking at it, that's probably a little bit too much. You need to jump to the next location, the next required image, take that. If there's a change in spectral patterns between this point, can you see me? This point and this point, then you got to go back and find out what happened. But if it's triphasic here and triphasic here, you know, I don't think scanning through that really slowly and carefully is worth your time. At least not, you know, color and spectral, and it's a lot of work, and you know, some patients are very difficult. So go ahead and jump. Now, if you have someone who's very diseased, you're going to be inching your way through because you're going to want to find everything that's going on. And typically, people don't just have one location of plaque. It's plaque type of distribution, and you need to look at all of them. So this kind of goes with the same point. You should have an idea of why the exam was ordered. Is this a new patient? Are we discovering peripheral arterial disease for the first time? If so, you need to do a thorough exam. But if you're evaluating for surgery, well, you might not have to do everything. They might already know about a number of things. They just want to say, tell me where a good location is to do a bypass. And so you might be asked to look at the vessel walls in the, I don't know, proximal femoral artery. For that matter, probably the proximal great saphenous vein too, if you're using the great saphenous as a conduit to go around an area of occlusion or extreme stenosis. So you could be looking at the condition of the vessel walls. Is there calcifications in the walls? That really precludes using that part of the wall. Existing collateral flow. What's already going on? Is there already been a collateral flow kind of created by the body? And that's important to know. You could be figuring out the person's already has a known history of peripheral arterial disease, and you need to know how urgent, how severe is it? Well, if they're worried about cutting off a foot or not, perhaps then you have a really good excuse to go straight to the dorsalis pedis, straight to the medial malleolus, finding arterial flow there, and reporting back to the doctor, hey, this is a known patient. We know we have multi-level stenosis, multi-level stenosis. And by the way, I couldn't find flow in the dorsalis pedis, and there's barely anything in the other artery. And then now it becomes an emergency case because this person needs surgery. immediately. Otherwise, their foot is a goner. So yeah, the surgeon may not be interested in the full exam. All right. So I kind of just drew out our little system here. Well, I guess I'll zoom in a little bit here. Better. I put the spectral in the profunda, or the deep artery, to remind me, because I want to make sure. I think I've already told most of you this anyway, but well, let me just go right to that. So let's see. I've got a little artery here. I've angle corrected there. Don't expect to find triphasic flow in this particular artery. And this artery doesn't go all the way down the foot. It dissipates into several or multiple branches rather quickly. I mean, some branches, yes, go into the lower leg, but for the most part, it feeds the thigh. So there is not as much Windkessel effect. So if your waveform is a little more like, waveform with the baseline, maybe just a little bit, kind of maybe like a biphasic flow. That's fine. That is okay for this vessel. The rest of the vessels that you see on the screen right now, we're going to want triphasic flow. If we don't have triphasic, we already have a problem. Now remember, you could take a triphasic flow, and if you have a poor Doppler angle, as in steering and heel towing, if you have a poor angle, you may miss triphasic flow. So you really have to get on your toe, you got to get on your heel, steer. Angle correct's not going to make a difference. Angle correct only changes your velocity, but the actual waveform. So let's just go ahead and kind of exaggerate a picture here so that we whoops, no, that's all right. So on this person, I got way on my heel. Maybe I steered it a little bit as well. I probably did steer it, but I did everything I could to get a good Doppler waveform, and sure enough, I get a triphasic. So that's what we want to see, something like that. We'll do one up here, one here, 1, 2, 3. Following that, triphasic waveforms all the way down. Remember, you could take a normal and make it look abnormal. It's very hard to take an abnormal and make it look normal. You almost have to be doing it on purpose if you're. Okay, so this is the knee, so we have popliteal here. Let's just say 1 and 2. I'll do a second one distally. Notice that I drew in the gastrocs artery. That might be the first artery that comes off that you notice if you're following this carefully. But that's going to just go up into muscle. And then you have your anterior tib. And I want to anterior tibial artery. Now, this is going to be distal pop / calf. All right, this gets a little harder to find. It's not easy to find the ATA on a lot of people. But if you really take your time and work on it, you should be able to find it on most people. Anterior tibial artery goes up, lays, It lays in a hammock between the tibia and the fibula. Show that on another image, but I want to point out this picture here. Now, I think I've already told you all this. This is a little bit repetitive, but worth mentioning because it does get a little confusing. When you have your transducer behind the knee, this is anterior. This is posterior. Opposite of what we're normally accustomed to. So when you have a vessel going straight down on your screen, that's going straight up on the leg. It's going anterior. That would be the ATA. That would be the ATA. In the tibial-peroneal trunk, from here to here is the tibio-peroneal trunk. Kind of difficult to get. Worthwhile trying if you're dealing with someone who has disease. You have to try. You definitely, you know, with the DVT studies, I kind of say, look, if you miss something, and you go down a little farther, and the blood flows good there, and the blood flows good here, chances of something being wrong in between are kind of low. So we don't, unfortunately, with this disease, with peripheral arterial disease, you really need to be trying your best to see everything. But you know, if you can get that, that's awesome. And if you really get to the point where, let's see if that's ATA. This would be the peroneal artery here and the PTA, posterior tibial artery there. If you get to those from behind the leg and get really the origins, that's wonderful. Like I said, do your best. Otherwise, we're going to get it in the calf. And I didn't draw the whole calf, but you guys know how to do that. And it's just like finding the veins, except with the addition of the ATA on the other side of the tibia. We are going to try to follow those as best we can. We're not going to be perfect, but we are going to do the best we can. And then down into the ankle. So this would be the medial surface of this person's ankle. Distal ATA. No, I'm sorry, damn it. Posterior tibial artery comes around the medial malleolus, medial side, and here is ATA, and as it goes over the foot, it's dorsalis pedis. Now, I've told you all in lab, we might as well, if you have no other information on the patient, or if you're really just, if like it's a screening test especially, you're screening for one, you don't know if the patient even has disease or how bad any kind of disease is. You could start down here. You could triphasic flow down here. You might be forced just by because you have to do the rest of the leg, but you know that there's probably nothing there, and so you can be a little more quick. It's a balance between doing due diligence, doing right by the patient, and doing right for yourself, because you know, if you have 20 more patients that day and you have a chance to go through someone a little faster, take that chance, or take that opportunity, I should say. So if we start down here and find triphasic flow, we're in good shape. If we find monophasic flow or tardus parvis, then we know what we're looking for. And like I said earlier, the other thing is the possibility of this is an emergency. Quick, tell me what's going on. Quick, tell me what's going on doesn't mean starting at the groin and working your way down. It means going straight to here and finding out what's going on. Geez, doc, I can't find any flow. That's what I was afraid of. Let's go straight to surgery. So, all right. You know what? Let me go over this verbiage over here, and then I just have some pictures. Oh, and I have a little reminder to myself here. Don't forget article. I've got a little article I want to go over with, and it's not that wordy, so that's a good thing. Okay, so as far as your velocities go, and we generally, there is a normal velocity. Well, I'm on the wrong chapter. Well, close to page 117, there is a normal velocity table, but that's not, I can, I did. And I have no idea why I put page 117 down, because that doesn't make any sense at all. That's like in the middle of the carotid, chapter 9. Okay. We generally don't refer to normal velocities. So, geez, you're in the femoral artery, and it's 120. Is that normal? Yeah, it probably is actually, but there are reference charts for that, but what we really worry about is before and after. So if you find a stenosis, you measure just prior to the stenosis. What does it look like just prior to the stenosis? What does it look like at the highest stenotic velocity? And from there, because especially with multiple disease locations, that velocity is going to be going down, 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 down as we go down. So between just before velocity, we could find a ratio. I'm sorry, guys. Let me. 177. That makes a little more sense. Oh, and then on page 176, there is a table that gives us mean velocities, but it's more of 177, table 12.2 or 12.2, where we look at the ratio. What's it? Ratio is called something. I'm sorry, I didn't write down the name of the ratio. I still don't see the name of the ratio. I'll try to get there. In any case, I labeled it as peak systolic velocity 2, meaning the stenosis, and peak systolic velocity 1, meaning prior to that stenosis. And I threw in some fake numbers here just to see what would turn out. And I have a ratio of 1.7. Now, I could tell you going from 110 to 185 is a stenosis. It's definitely a stenosis, although hemodynamically speaking, it's probably not dropping the pressure too much. Remember, it's the pressure drop that counts. And so I kind of rewrote table 12.2 here. So if we have a peak systolic velocity ratio, I guess that's what it's called, the PSV ratio, of less than 2, then the stenosis is less than 50%. So 1.7 is definitely less than 2. I said the stenosis is less than 50%. If it is equal to 2 to 2.5, we were talking about moderate disease, and the stenosis itself is around 50 to 69%. Remember in the carotid, we can measure the stenosis, like literally putting our calipers and trying to measure the stenosis, but it's actually harder than it looks. There could be more or less residual lumen than we think we're seeing, but the velocities don't lie if you do them correctly. So that's kind of the gold standard, is the velocity, the spectral. So moderate disease, if you have a ratio peak systolic velocity is of 2 to 2.5, it's somewhere between 50 and 69%. Severe disease, 70 to 99% stenosis, you have greater than or equal to 3 to 3.5. And then 100% stenosis, there's nothing to measure. So that is that. Kurt, don't forget article. Okay, but I need to go do something first. Prior to article, we have got some pictures. Pictures are always a good thing. I didn't mention this, so let's go over here first. Just so you know, contrast arteriography versus what we do, duplex. Go in a little closer here. This picture is okay. But we can see clearly there's something going on right there and right there. Let's see, so that's, oh, this is actually, oh, I love this. I love this. Femoral pop. Probably the pop. It looks like there's something going on in the pop, like it changed direction all of a sudden. That looks like collateral flow right down there. So it looks like some severe disease in the pop. But look at here, this is the deep. Major branch, 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 branch. So that's why I say you're not going to get the Wind-Kessel effect in the deep. It's simply not going down all the way to the ankle. It's only going to about the knee for most of the time. And like I said, this is a change in direction right here. So it looks like a severe issue in the popliteal, but not to mention there's severe issues, significant issues all throughout. So this person has multi-level femoral deep popliteal disease. Is this all the same? I think it's all the same person. It's hard to tell. The first picture is easy enough, but getting a little difficult to see what's what. But obviously we have like trickle flow here, trickle flow there. Perhaps even maybe a collateral doing that. Anyway, you get the idea. Arterial ram, and then there's ours. Let's see. That's pretty standard there. Let's just kind of start up high here. 1.5. I drew that rather messily because I was trying to remind myself that an aneurysm Sometimes an aneurysm, like in the case of the aorta, is defined by its size. In this case, in the legs, the extremities, an aneurysm is just get rid of more of that, 1.5. Let's see, the diameter is 1.5 times previous. Segment. In other words, if you're coming along and the diameter here and the diameter here, if this diameter is 1.5 times larger than the previous diameter, the previous segment, or I could say the more proximal segment as well, that's the definition of an aneurysm. Right distal thigh pop. So high in the popliteal, low in the distal femoral. They're not 100% sure. They have a nice aneurysm here. I don't know if you could see. I'm going to kind of draw in a residual. God, I can barely see it myself. I think I'm drawing in the residual lumen there. So remember, that means all of this, and you see like layers here, all of that is thrombus. That breaks off, blue toe. As just another image here with nice color showing reversal of flow, and looks like some disturbed flow in there as well. This thrombus looks like it's being, or I mean this aneurysm looks like it's filled somewhat with thrombus as well. It's a little funny looking. Oh, this picture, awesome. This picture is awesome. So you guys can see, most likely, you can see the stenosis right there. So we're starting to get aliasing in there, and the aliasing continues. So that jet is really boring going through that, that artery even after the stenosis. But look what we have here. That is a color bruit. If they put the if you listened to this, you would hear the vibrations. So basically, yeah, this is, as it's going through, it's vibrating the tissue around here. So this is one reason, by the way, you don't want to have your gain too high, because you could fake a bruit, right? And no one likes fake bruits. All right. Let's see, where else are we? I know I'm kind of all over with these. I just grabbed these pictures as I found them and as I was looking for them. One of the drawbacks of doing exams, we've already talked about if you have an ABI and your ABI number is exceptionally high, more than 1.3, that means your blood pressure in your ankle is considerably higher than the blood pressure in your arm. And that's like, well, wait a minute, why is that? Well, it's not the blood pressure that's high, it's the calcifications in the wall. You can't even close that wall because it's literally like a rock. And that happens to all the time, and it happens mostly in diabetic patients. Diabetic, generally the ones who have calcifications. And you could actually see shadowing coming through there. And also the loss of color and poor Doppler angle. Just notice that. Poor angle. What was this person thinking? Look at this. Let me just draw the box in case you can't see it. That's not sliding downhill. This guy needs to go to my lab and learn how to slide the box downhill. It should be going the other direction. They should be on their toes. Maybe that's why. Maybe it's not calcified. It's not calcified at all. It's just wrong. Okay, let's just look at this. I don't even know where this is in the body. I had the hardest time finding, oh, that's the other thing. I know, I'm jumping all over the place, but just deal with it. That's the other thing. This is normal, triphasic flow. Beautiful triphasic flow here, high resistance. And then we have really low resistance here. Okay, did the patient just exercise? If they exercise, if this was like you had them jump up and walk up and down the hall, do some squats or whatever, this is good. Their leg goes from this to this very quickly. And in a healthy individual, this happens very fast. All the arteries open up. They're like, come on, come on, come on, give me all the blood you can. I'm working out here. If this person is at rest, that is a really bad sign. If this person is at rest, that means O2 is way down, and they're basically ischemic. I couldn't think of the word. Ischemic or exercise or ischemia. What is going on? Well, if it's your patient and they've been laying there for 20 minutes relaxed and it looks like that, that is not normal. I only grabbed this one because look at this. The color is correct, yes. Blood going towards the camera is red and away from the camera is blue. This isn't the biggest deal in the world, but you might have a doctor who doesn't like this at all. They stopped, they hit freeze, or they switched from color to spectral right there. They just chose the exact wrong time to hit the freeze button or to switch from one mode to the other. And so the flow is going backwards because, yeah, red is towards the camera. This is towards, wait a minute, this is common femoral artery. Chances of this isn't going backwards. And I think this might be vein center at, yeah, same person. So maybe they were showing this. I just grabbed these images. And maybe this is what the whole article was about. Now it's red. Well, that's because they captured that part of the wave. And so pay attention to those types of things. That's not terribly important, but like I said, you might have some doctors who do not like that at all. All right, I'm going to drop that, and we're just going to look at this. I just put this up, course content. I just threw it in there as this is under course content. Interpretation of peripheral arterial and venous Doppler waveforms. I actually think they have some. I think they have some central arterial and venous as well in this one, but. We don't need to read through, whoops. Don't need to read through all of this. Don't need to read that. There's some clarification. So even the fact that I'm using the word triphasic is questionable. In the case of the leg, it does mean something, but they're actually trying to get away from that because there's a lot of incorrect usage. Your screen sharing is paused. Oh, no one told me. No one told me, guys, that you weren't seeing what I was seeing. Okay, you guys you're seeing a new screen, right?
Yes.
Yeah. Okay. So here, let me just. Well, I'm not going to back up. No need to back up. It's just a bunch of words. Okay. Triphasic. Okay, so that's pretty well established. There's spotlight. Okay, that's the second time today my spotlight didn't work. So I got a little arrow and that works. Triphasic is pretty well established. That's one reason why I'm not afraid to use that term, because it really means above, below, above. It has to cross the line twice. So above, below, above, above, below, above, above, below. That works out pretty well. Biphasic is a little different. This one is above, and it has a little bit of a different wave there, but really this could almost be monophasic, as you see below. This one's biphasic. It does cross the baseline once, but then it stays below the baseline. This person has a kind of like a reversal of flow in this artery. Perhaps reflux is going on somewhere. And then this is biphasic. I don't know. I mean, that looks like monophasic. Monophasic, their drawing here is really just a really tardus parvus type, weak, blunted waveform, but it doesn't have to be tardus parvus. These are sharp, but there's one pulse really. I can see this going monophasic and that monophasic. But there's a lot of overlap between monophasic and biphasic. So wording gets a little funny there. Why not? Okay. So it goes on to talk a little bit about the nomenclature. We're just going to look at the images. Sorry, my little mouse isn't working, so I'm having to go through the screen for some reason. Usually happens when my machine's about to crash. Arterial. Key descriptors. I think we've used most of these, but let's see if there's some. Flow direction, antegrade. That's going in the direction it's supposed to be going, not necessarily up. It's just antegrade is going the direction it's supposed to be going. Retrograde, backwards flow. And that might be normal. It could be antegrade, retrograde type of stuff, or it could be abnormal. Bidirectional. It's going in above and then below the baseline, and absent, of course. Phasicity, multiphasic, monophasic. Resistance, high, intermediate, low. The upstroke, high, intermediate, low. I'm sorry, rapid or prolonged. Rapid normally is good, prolonged, tardus parvus. Sharp peak, spectral broadening. Oftentimes spectral broadening doesn't matter. Sometimes it means something. Staccato. Staccato is the closest term that I could find to that thing that I'm looking for. But staccato, we'll talk about staccato in a second. Dampened, kind of the same as tardus parvus. Reversal, And then there's veins. It's a lot of the same things. Respirophasic, respiratory phasicity, decreased pulsatile continuous regurgitant, spontaneous, non-spontaneous, reflex, and all that. Okay. Oh, good. My mouse is working again. Flow antegrade. Okay, so this is what they're saying here. What they're saying is this is retrograde. Well, assuming everything is set up correctly, and this is definitely an artery, and this is below the baseline, they're showing retrograde flow, and that might very well be. This is antegrade because, well, the vessel's generally going in the correct direction. It has reversal of flow, but that's normal. Bidirectional, look at, and this is what you hear. Get up closer, you hear me. This is typical of a aneurysm. If you're looking at the neck of a pseudoaneurysm, the blood goes in and then back out, and in and back out. So that's one thing. Absent flow, I want you to pay attention to this. This is noise. If you have equal noise on either side, it's not blood flow. If there was more on one side, you could say that it was venous flow. I have to keep getting in and out of this. Yep, and now I'm picky today. So now they're calling, instead of triphasic, they want to call this multiphasic. Both triphasic and biphasic, call it multiphasic. All right, fine. Monophasics here, these are both monophasics, those are pretty good. High resistance, you guys know if there's zero or very little flow in end diastole, it's high resistance. Intermediate resistance, so there's flow, but not a whole lot. And then low resistance, you guys know what that is. Plenty of flow in end diastole. Rapid upstroke is usually a good thing. So this is usually a pretty good thing to see, rapid upstroke. This one's a little delayed. All right, prolonged upstroke. Sharp peak, spectral broadening. So oftentimes a bad sign that you're post-stenotic. And here's a staccato. That is like, this could be before an occlusion. So the artery is going boom. You know, it's like it's a sharp speed up and then immediately slow down because basically it's hitting a wall. So staccato could very well be an indication of a oncoming stenosis. That first one in blue is tardus parvis. This next one could almost be it's a steel. It's oscillating, going back and forth. Well, the last one there, you guys should recognize this guy. Oh, we had such a wonderful conversation about this guy. I loved it. I'm sure you guys did too. That looks a little bit like our bunny rabbit, all right? It's kind of a sad bunny rabbit, but it's a pre-steel type of waveform. Let's see. Antegrade venous flow, although surprising amount of arterial heart contractions in there. Retrograde for a vein is above the baseline, no flow. Phasics. Pulsatile venous flow if you're very close to the heart. Cardiophasic. Let's see, major descriptors. Continuous flow, regurgitant flow. This could be actually near like like really close to the heart. If you have a valve that's faulty in the heart, it's actually the blood's going out and then right back into the heart. Spontaneous flow is good to see. That's all right. Let me just put it so that at the top of your screen, that's good in the veins. If you're not getting spontaneous flow, if it's in the thigh or pop, that's not a good sign. But if you're all the way down close to the ankle, don't expect to find spontaneous flow, but you should be able to do a compression maneuver or an augmentation. Let's see. Wow, what is this going on with this person? That first one, I don't even know what I'm looking at. Changes in venous flow. Valsalva maneuver stopped it, so I don't know. Calf augmentation, augmentation, augmentation. Reduced augmentation, loss of increased venous flow velocity, dampened augmentation in response to adequate distal muscle contraction or compression maneuver in response to adequate. Okay. Generally, you want to see more than, just to the top. You want to see more than that for augmentation, but sometimes it just depends on how good your augmentation is. We don't need the fistula flow. Normal resting arteries. These are all kind of peripheral arteries, and I'm not going to go through all of these. Normal peripheral arterial waveforms following exercise or increased body temperature. Okay, stenosis, and you can just kind of tell by the look of this that this first one, the blue one there, is a bit of a stenosis, not horrible. And we're starting to get worse and worse as we go down here, as higher velocities, 400 centimeters per second. Distal, here at the top here, the top three are distal to a stenosis, so they're showing tardus parvus waveform. Proximal to an occlusion, so a little bit similar to the staccato, although not nearly as much, is like forward flow and then just absolute stop. Let me read something. In the absence of flow, limiting stenosis proximal to the site of Doppler sampling, the waveform is characterized rapidly and may be high resistive or intermediate resistance. Oh, okay. Pseudoaneurysm, that's to and fro, back, forward, back, forward, back. Arteriovenous fistula, you have venous flow with an artery, really arterial flow inside the vein. That makes a very messy look. We can skip through those or all, although we can. That's a subclavian vein here at the top, although that looks a lot like remember the veins in the hepatic veins? It's the same waveform because really they're both equidistant from the heart. It's just, that's basically heart flow there. Continuous, we don't need to go through all of that. CCAs, ECAs, bulb, don't even bother with the bulb, it just makes an ugly waveform. It's like some tardus parvus going on there. You have distal. Well, in any case, this is, some great stenosis here. There's our staccato Mercado, let's see. Okay, I think, oh my God, it just keeps going on. There's a nice bunny rabbit. Vertebral steel there. Partial steel, and then the one at the top now, I thought that might be, when we saw this earlier at the very beginning of this article, that's a reversed flow complete vertebral steel. So that's arrhythmias, you'll see those. The heart doesn't always beat at the same rate. So this is just if you guys are interested, and I hope you are, because waveforms matter. They really do matter. This is just a great article to keep kind of in your back pocket, keep on your computer too, even on your phone, because when you're out there in the field and you see something you want to try to explain better. Whoa, that's weird. You can come back and find what you're looking for. Man, this is just a wealth. Oh my God, this is awesome. I'm so excited I found this. Okay. Oh, and there's a little continuous wave Doppler here. In fact, those at the top of your screen are all continuous wave Doppler waveforms. Okay, finally, right? Man, I didn't think that was ever going to end. Sorry, I forgot.
Mr.
I just found this article.
Are you going to send that file to us?
I already did. It's it is. Yeah. Oh, you are looking at this. Why doesn't? All sorts of waveforms. Fun. All right. It's under course content in vascular imaging 2. Yes, correct class. So, all right. Well, don't need to continue